primary goal of treatment and rehabilitation. MBCT is an acceptable brief intervention to combat PTSD with potential for reducing avoidance symptom cluster and PTSD cognitions. MBCT is known to have large effects on quality of life and health-related quality of life in normal population. It has been stated that active involvement by those with SCI in recreational activities increases their likelihood of employment and hence improvement of the overall quality of life. In India, there's a significant scarcity of OT practice, specifically within the field of mental health. Usually the physical part of any injury is given due importance and the psychological aspects are neglected. Concepts such as MBCT and recreational-based therapies are practiced more in the Western world. The present study would help us to identify and establish a valid protocol for dealing with psychological morbidities and improving quality of life in spinal cord injury patients. Additionally, the study aims to redirect focus towards the mental health components associated with the neurological conditions and the role OT plays within this context. So aims and objectives. The aims is to establish the efficacy of MBCT and recreational activities on PTSD and quality of life in traumatic spinal cord injury patients, and the objective is to reduce the stress levels and to improve the quality of life in the population in question. So the hypothesis is there is a significant difference of MBCT and recreational activities on stress and quality of life in patients with traumatic spinal cord injury, and the null hypothesis suggests that there is no significant effect of MBCT and recreational activities on stress and quality of life in patients with traumatic spinal cord injury. So the study design was a pre-post test experimental study design. Study population was spinal cord injury patients, traumatic onset with all level of lesions. Sample size was 30. Sampling method was random sampling. Inclusion criteria was traumatic SCI, Asia A to D, age range of 18 to 16 years, both males and females. Subjects having mild to extremely severe stress on DAS21 and subjects able to read and write in at least one Indian language. The exclusion criteria was non-traumatic spinal cord injury, subjects having DAS21 score of less than 14, that is the cutoff criteria for stress, currently under any other psychotherapeutic treatment, taking antidepressants or mood stabilizers in the last 2 months prior to inclusion in the study, or having any acute suicidal ideations. The screening tool used were medical records and history taking, Asia impairment scale and DAS21. Outcome measures were DAS21 and WHO QOL BREF. So the MBCT manual by Williams and Segal was obtained from open source and the concerned audio files were purchased from the Guilford Press. A total of 30 subjects were taken for the study according to the inclusion criteria and were administered with MBCT and recreational therapy protocol for a period of 8 weeks. One session for 2 hours per week followed by a 15-minute session of recreational activities was given to the patient, and therapy was administered in a group mode. The size of the group differed from 3 to 10 depending on the availability of the patient and the therapist. So this is the elaborate MBCT protocol for a period of 8 weeks. So discussing each and every part is not possible because of the time limit, but mostly it consisted of body scans, meditation, breathing exercises, building pleasant experiences calendars, and bringing awareness to routine activities. So this is the orientation program wherein the patients were told about the therapy and how it works. Patients performing sitting meditation, patients performing combined stretch and breath meditation and mindful movements. The recreation activities were based on the interest of the clients and took into consideration their cultural beliefs. Carom board, story narration, charades, and some other fun and enjoyable activities were provided to the patients. So patients indulging in carom board activities. So here the patient is blindfolded, and on verbal command he has to pinpoint the tail on the donkey. And as soon as he's successfully able to do it, positive reinforcement is given to the patient in the form of appreciation and clapping. And as soon as the blindfold was removed, the patient himself laughed and had fun during the activity, thus reducing his stress level. A total of 30 SCI patients were included in the study, 23 males and 7 females. The age range of the participants was 36.3 plus minus 5.6 years. Out of 30 patients, 16 were Asia D, 6 were Asia C, 4 were Asia B, and 4 were Asia A. 6 subjects were found to be suffering from mild stress, 16 from moderate stress, 7 from severe, and 1 from extremely severe stress. A Wilcoxon signed rank test revealed that the stress score on DAS21 scale was significantly lower after the intervention, the median being 20 as compared to before the intervention, suggested median being 23, and the p-value and the z-value indicate that there is a significant difference pre-test and post-test. So as you can see, post-test the mean stress score decreased quite a lot. The Wilcoxon test was further administered to evaluate whether there were any changes post-intervention in the quality of life of the SCI patients. The test revealed a statistically significant increase in the quality of life post-intervention as indicated by the p-value. So here we can see that the post-test mean after the intervention increased on the WHO QOL BREF scale. ANOVA was further utilized to analyze the improvements in quality of life between mild, moderate, severe and extremely severe stress groups. It was seen that no significant differences existed in terms of improved quality of life between these groups. However, the mean score of improvement was in the order mild, moderate, extremely severe and severe stress groups. MBCT encourages participants to cultivate a new way of engaging in their thoughts and emotions, emphasizing a non-judgmental and accepting stance, thus helping in devoting a sense of personal control and mastery for the clients to manage their stress level better. Return to recreational activities post-injury is often not the primary goal for rehabilitation team. However, life after SCI cannot be complete without the possibility of continuing pre-injury interests or without the ability to find other pastimes that are adapted to the disability. The present study successfully establishes the role of MBCT along with recreational activities in improving PTSD and quality of life post-traumatic SCI. While individual psychotherapy sessions typically foster a stronger rapport between the client and the therapist, the study revealed noteworthy findings despite providing group interventions. Participants experienced increased self-confidence due to greater social engagement. It was seen that the clients having a better educational background appreciated the intervention better. A few limitations were encountered in body scan techniques in patients having some sensory issues. Patients with mild and moderate stress level responded the best to treatment, thus indicating that addressing these aspects through mindfulness and recreation-based intervention could help establish a valid treatment protocol for psychological morbidities and enhancing QOL in the future. This would help to shift the focus of neurorehabilitation to a more comprehensive and holistic therapeutic treatment approach. So the limitations of the study were a small sample size, the type, that is complete or incomplete SCI, and the level of injury, cervical, thoracic and lumbar of the SCI patients was not taken into consideration. The duration of the injury for subjects were not taken into consideration as there are changes in psychological symptoms from acute phase to chronic phase, and the population from only one region was taken as subjects. As some theoretical frameworks of the protocol were made to be translated in regional language, maybe accuracy was compromised. So these are my references. Thank you.
Shaima Nazim from Bhubaneswar. My topic is correlation between mindfulness and emotional regulations in college-going students of age group 18 to 25 years.
Today I am going to present my topic titled Correlation between Mindfulness and Emotional Regulation in College-Going Students of age group 18 to 25 years. Beginning with the introduction, mindfulness is the psychological process of purposely bringing one's attention to experiences occurring in the present moment without judgment, which one develops through the practice of meditation. Emotional regulation is the ability to respond to the ongoing demands of experience with a range of emotions in a manner that is socially tolerable and sufficiently flexible to permit or delay spontaneous reactions as needed. Emotional dysregulation has been defined as difficulties in controlling the influence of emotional arousal on the organization and quality of thoughts and actions and interactions. Individuals who have difficulty in emotional regulation exhibit patterns of responding in which there is a mismatch between their goals, responses, expression, and the demands of the social environment, which causes problems that interfere in their occupational performance and participation in work, ADL, leisure, and social participation. Therefore, occupational therapists must attempt to enhance the emotional regulation. The rationale of the study is, although it has been shown in researches that mindfulness and emotional regulation are related, the nature of the relationship and the underlying processes are still not fully understood. These researchers suggest that higher the mindfulness, higher would be the emotional regulation, and lower the mindfulness, lower would be the emotional regulation. All the present literature which are available are from Western context, and therefore an attempt has been made to explore it in Indian context. Also, the relationship between mindfulness and difficulties with emotional regulation is not yet clear and needs to be assessed. Moreover, R.N. Singh 2020 has done a study which indicates that emotional regulation has been associated with suicidal ideation in young adults. So we attempt to find out emotional regulation in college-going students. The aims of the study are to find out the relationship between mindfulness and emotional regulation, and to find out the relationship between mindfulness and difficulties in emotional regulation. Objectives of the study are to assess mindfulness in the individual, to assess emotional regulation, and to assess difficulties in emotional regulation. Hypothesis. Alternate hypothesis 1, there is a relationship between mindfulness and emotional regulation. Alternate hypothesis 2, there is a relationship between mindfulness and difficulties in emotional regulation. Null hypothesis 1, there is no relationship between mindfulness and emotional regulation. And null hypothesis 2, there is no relationship between mindfulness and difficulties in emotional regulation. Methodology. Research design selected for this study is correlational study design with a sample size of 50 students. Sampling type was of convenience sampling, and method of data collection was online via e-forms. Inclusion criteria. Students of the age group 18 to 25 years, both male and female. Exclusion criteria. Students who are disabled or have any chronic illness. Students diagnosed with any type of diagnosed mental health issue. Withdrawal criteria. Any condition that needs immediate medical attention, or incomplete or missing data. Outcome measures. There are 4 outcome measures selected for this study. 2 outcome measures were selected to assess mindfulness, which are Mindfulness Attention Awareness Scale and Cognitive and Affective Mindfulness Scale Revised. To assess emotional regulation, we have taken Emotional Regulation Questionnaire, and to assess difficulties in emotional regulation, we have taken Difficulties in Emotional Regulation Questionnaire 18. The procedure of the study was conducted in agreement with the national and international regulations and the Declaration of Helsinki. Full information about the study requirements was provided to the participants, and they required to accept the data sharing and privacy policy before participating in the study. Participants were selected as per convenience sampling. Informed consent along with the questionnaires was sent online through email with the link of e-forms. Data analysis. After the completion of the questionnaires, data was downloaded and converted into master chart into Microsoft Excel sheet. Data was analyzed with the help of a statistician. The SPSS software version 22 was used to analyze the data. The Pearson correlation statistical tool was applied. For the statistical test, the level of significance was set at p-values less than or equal to 0.01 or less than and equal to 0.5 respectively. The results and discussion. Association between mindfulness and emotional regulation. On analysis, the relationship between mindfulness and emotional regulation has shown a weak linear relationship between reappraisal and mindfulness. The results were supported by the findings of a study by Christina L.M. Hill et al. 2011. Her study indicated that higher level of mindfulness were related to higher level of emotion differentiation for both negative and positive emotion. This scatter plot summarizes the result. For the association between mindfulness and difficulties in emotional regulation, there are 6 subcomponents of difficulties in emotional regulation, which are awareness, clarity, goals, impulses, non-acceptance, strategies, and total. On analysis, it was found that there is a strong inverse relationship between clarity and goals and mindfulness. This scatter plot summarizes the result between clarity and goals. Also, the present study, the results were supported by the findings of the study by Sunil van der Merwe 2015. In the present study, also we have taken age group 18 to 25 years, which is supported by another study done by Brockman R 2017, which suggests that an important factor moderating the effect of daily reappraisal on negative affect is a person's maturity. For the younger adults in the sample, daily reappraisal was associated with more negative effect, but for those who are 20 years and older, reappraisal was associated with increasing benefits to emotional well-being. Hence, both our alternate hypotheses have been accepted. Conclusion. The study highlights the association between mindfulness and emotional regulation and the relationship between mindfulness and difficulties in emotional regulation. The present study provides evidence that mindfulness is related to emotional reappraisal. Since mindfulness and difficulties in emotional regulation are inversely correlated, we may conclude that practicing mindfulness will help reduce difficulties in emotional regulation. Limitations and future recommendations. The limitations of the study are that sampling was of convenience and the sample was drawn from a single university. Therefore, it cannot be assumed to be representative of the larger population of young adults. Future studies can be conducted with a large population. Also, all constructs were measured exclusively using self-report questionnaires. All the findings are largely based on participants' perception of their level of mindfulness and emotional regulation, which may not reflect the actual level of mindfulness and emotional regulation. Additionally, it was challenging to reflect participants' underlying mental health condition, as it was a self-reported survey done online. Furthermore, the participants were not screened for prior mindfulness practice or beliefs, which can limit the extent to which causality can be inferred. Emotional regulation and difficulties with emotional regulation can be compared with people who practice mindfulness and people who don't practice mindfulness. Or an experimental study could be done to understand the cause and effect of mindfulness-based therapy on emotional regulation and difficulties in emotional regulation. Following are my references. Thank you.
Elderly population is defined as people aged 65 years and above. In the year 2022, elderly population was 771 million and 149 million globally and in India respectively. It is estimated that it will reach 1.5 billion worldwide and 319 million in India in the year 2050. Aging is a dynamic and progressive process bringing about numerous morphological, functional, biochemical and psychological changes, and it is an important factor for cognitive decline and dementia. Mild cognitive impairment is a risk factor for developing dementia, and 8 to 15% of these individuals progress to dementia, which places a great economic burden and more people with decreased quality of life. Cognitive training improves plasticity, cognition, and cognitive reserve capacity of the brain, especially in elderly with MCI. Also, physical exercise was shown to be favorable for unspecific cognitive abilities in older individuals with and without MCI. Occupational therapists propose cognitive training interventions to prevent and maintain or delay organic and functional changes in elderly. Need of the study. It is vital to address elderly with MCI to either return to the normal cognitive functions, maintain the current level of their cognitive functioning, or slow the rate of conversions of MCI to dementia. Although there are numerous studies on various interventions for MCI, there is insufficient evidence on cognitive intervention to improve MCI and also evidence in this area related to occupational therapy intervention. The aim of the study was to assess the effect of adapted cognitive intervention on elderly with MCI. Objectives: to determine the demographic data with the outcome measures, to obtain the scores of MOCA, LOTCA, and FAQ, that is the Functional Assessment Questionnaire, before and after intervention within the control group, to obtain the scores of the outcome measures before and after intervention within the experimental group, compare the scores of the outcome measures within the control group, compare the scores of the outcome measures within the experimental group, and compare the scores of the outcome measures between the experimental and the control group. Hypothesis: null hypothesis, adapted cognitive intervention plus TAU, that is treatment as usual, is not effective in elderly with MCI as compared to physical intervention plus TAU. Alternate hypothesis, adapted cognitive intervention plus TAU is effective in elderly with MCI as compared to physical intervention plus TAU. The study design was a quasi-experimental study design. Study setting was at the tertiary hospital setting. Recruitment was using non-probability purposive sampling, and 30 individuals with MCI were selected as a sample size. The study duration was of 1 year. Confidentiality was maintained and ethical approval was achieved. Eligibility criteria: inclusion criteria were individual aged 65 years and above and a MOCA score of 24 to 26. Exclusion criteria: elderly who were unable to walk independently, elderly with mental health issues that was identified based on GHQ 12 and based on the medical records, and elderly with other neurological disorders based on the medical records. So a total of 364 individuals were assessed for eligibility. 334 were excluded as 233 did not meet the inclusion criteria, 29 did not give consent, and 72 were meeting the exclusion criteria. So finally 30 were recruited and 15 were allocated to the intervention group, 15 to the control group. 15 were followed up in each of the groups and there were no loss to follow up, so 15 were analyzed for each group. The experimental group interventions. The cognitive intervention was adapted from a study published in the year 2003 titled Cognitive Rehabilitation Occupational Therapy for Individuals with Dementia. The purposeful activities included other card games, word puzzles, memory games, craft activities, music, gardening, woodworking, exercising, throwing rings and sandbags while sitting, balloon volleyball, puzzles and stacking cups. They also received the physical intervention that consisted of a 5-minute warm-up period, 20 minutes of the main exercise and 5 minutes of cool-down periods. This was taken from 2 study studies published in the year 2016 and 17. The control group also received the physical intervention, and both the groups received the treatment as usual. So the total number of sessions were 20 sessions per individuals. Frequency was 5 days per week for 4 weeks, and duration was 45 to 1 hour per session. The outcome measures used were the Montreal Cognitive Assessment (MOCA), Lowenstein Occupational Therapy Cognitive Assessment (LOTCA), and the Functional Assessment Questionnaire (FAQ). Data analysis was done using the paired t-test for statistical analysis pre and post examination within the control and experimental group. Alpha level was set to 5%, and unpaired t-tests were used for analysis between the control and experimental group. So this is the demographic characteristics of the participants. So there were a total of 30 participants, 16 males and 14 females. The mean age was 69.1. There were 11 participants with primary education, 11 with secondary, and 8 with graduation. So if you see the distribution among the intervention and the control group, there is a more or less homogeneous distribution in the control and the experimental group. This is the graph showing the analysis within the experimental group pre and post test for MOCA. So you can see there is an improvement post intervention in the MOCA within the experimental group. This is for LOTCA within the experimental group, and you can see the improvements post intervention. This is the graph for FAQ. So there is decrease in the FAQ score, which is a positive result, but only in a few of the subjects. So we'll see it in detail. So pre and post test analysis within the group for MOCA was statistically significant, as the p-value is less than 0.05 and an effect size of 3.61. Pre and post test analysis within experimental group for LOTCA was also statistically significant, as the p-value is less than 0.05 and an effect size of 2.67. For FAQ, pre and post test analysis was not statistically significant within the experimental group, as the p-value is greater than 0.05, but there is an effect size of 0.48. This is the analysis in the control group. So there is some improvements in the control group post intervention on MOCA, some improvements on LOTCA, and minimal improvements is seen on FAQ within the control group. So pre-post analysis within the control group was statistically significant with a p-value less than 0.05 and an effect size of 2.04. For LOTCA within the group analysis was also statistically significant with a p-value less than 0.05 and an effect size of 1.84. For FAQ, pre and post analysis within the control group was not statistically significant, as the p-value is greater than 0.05, but there was a small effect size of 0.38. This is a graph comparing the experimental and control group for MOCA. So the pink is the experimental and blue is the control group. So you can see that the experimental group improvements was much more than the control group. Similarly for LOTCA, yellow is the experimental, blue is the control group. The improvements in the experimental group is more in comparison to the control group. With regards to FAQ, there is no much significant difference that is seen between the group. So pre and post for MOCA, that is between group analysis, was statistically significant with a p-value less than 0.05. For LOTCA, between group analysis, again it was significant with a p-value less than 0.05. But there was no statistically significant difference on FAQ pre and post test, as the p-value is greater than 0.05. Discussion. The experimental group consisting of adaptive cognitive intervention and physical intervention showed significant positive effect on the outcome measures MOCA and LOTCA, suggesting it produced an effect on cognition on elderly with MCI. These finding is consistent with the previous meta-analysis that concluded combined cognitive and physical exercise intervention improved global cognitive, ADL, and mood in older adult with MCI. The control group also showed statistically significant improvements in two outcome measures MOCA and LOTCA, that is again consistent with the previous studies. On FAQ, that is one of the functional measures, it is found that there is some improvement shown in the experimental and the control group, that is within group analysis. However, this improvement is not statistically significant. Also, there is no statistically significant difference in the experimental group as compared to the control group, that is between group analysis on FAQ scores. These findings could be due to the short duration of the study, as demonstrated by a previous study in 2019, which reinforces the notion that longer durations may be able to show greater effects on functional outcome. The study also conveys that there was a significant difference between control and experimental group on the outcome measures MOCA and LOTCA. There appears to be a merit in the adaptive cognitive intervention approach in elderly with MCI than using physical intervention approach alone. This finding is supported by a systematic review and meta-analysis published in the year 2018 that combined cognitive activities and physical activities induced significantly larger improvements in cognitive functioning in older adults than physical activity interventions alone. Limitations of the study. The study had a quasi-experimental design with pre-test and post-test without randomization, which poses a methodological limitation. Further, the sample size of the study was small, hence future study is suggested to recruit a larger sample size using randomization. The short duration of the study was an important limitation of the study, hence future studies are directed to conduct for a longer duration to get better results on the functional outcome. Implications: the adapted cognitive intervention protocol can be used to treat elderly people with MCI. Thank you. The statistical analysis of the study can be used to design a definitive randomization control trial. Conclusion: the adaptive cognitive intervention showed significantly greater improvements as compared to the control group on outcome measures MOCA and LOTCA. On FAQ, the experimental and control group showed some improvements on the functional activities in elderly with MCI. These are my references. I'd like to acknowledge my participants, our dean and our guide. Thank you.
Good afternoon, all of you. My topic is dysphagia in chronic lateral medullary syndrome. So dysphagia means difficulty swallowing, which is a very common associated problem with the stroke, and particularly lateral medullary stroke, because it is happen in the brain stem. This has been documented that 10% of lateral medullary population of stroke, they have persistent dysphagia for months and years, and till now there is no documentation of this kind of population, that what is happening to that. They all are on non-oral feeding, either from the nose pipe or directly pipe from the stomach. So lateral medullary stroke is also known as lateral medullary syndrome, because the medulla is responsible for many other functions of the brain, like balance, coordination, and this is the MRI image. So lesion of medulla looks like the arrow, pointed arrow. This is the pictorial image. So as you can see, the lateral medulla part, they consist of major nucleus of cranial nerves, lower cranial nerves, which is directly responsible for the act of swallowing and even your balance, coordination and voice. So that is why it is also known as lateral medullary syndrome. So abnormality in upper esophageal sphincter and the pharynx is the main problem has been seen in the lateral medullary syndrome. As you can see in this image, the patient is trying to swallow. This white opacity is the food, and after repeated trying, it is not passing through the food pipe. It is just getting stuck in the pharynx. So this is the main feature of the lateral medullary syndrome, and ultimately this patient all they cough out, even they don't able to swallow their own saliva. So till now, these are the some basic treatment strategies which have been tried, like normal conventional swallow therapy consisted of jaw exercise, tongue exercise, pharyngeal exercise. But in these kind of population, many surgeons have tried some surgical intervention also. What they have did, they put a Botox on the upper esophageal strictures to relax the food pipe so that food passes inside. But nothing has been proved good and functional, and rather they have documented side effects, because when you are relaxing the food pipe, even regurgitation and vomiting, these are the side effects. So till now there is no documentation of this 10% of chronic medulla dysphagia population. So these were my objective: to characterize and understand the extent of functional impairment in the swallowing phase, to strategize the non-invasive methods, and to document swallowing outcomes of severe dysphagia in chronic lateral medullary stroke. So my study design was ambidextrous study and done at a tertiary care center, and this was a 6-year period, because these cases, to get these cases is very difficult. It's a long-standing case approved by Institutional Ethics Committee, and the clinical picture was inability to swallow. Those patients were enrolled, and my study endpoint was to get the eligibility to have a safe oral feeding, so that they can be independent on oral feeding with having these outcome measures on the eligible range. My inclusion criteria, as I said, I took cases only which is 1 year and above, and no surgical intervention was they had in the past, and functional oral intake scale was 2 and less. Exclusion criteria: unable to comprehend, tracheostomized patient, and lost to follow-up. So we did the assessment by two ways. One is clinically and one is objectively. Clinically, like we assess oral phase, pharyngeal phase, different food testing, and objectively also we did through the video fluoroscopy, swallowing steady. I will show it in my next video. This is the basic scale through which we categorize the severity of dysphagia. As you can see, 1 to 3 are the dependent on the tube feeding, and once patient is achieved 4 or above, we can remove the feeding tube and can be on the oral feeding. So all cases of us was on functional oral intake scale 1. So this was the method of VFSS, we call video fluoroscopy study. In this, we take patient in the radiological suite. It's a kind of live X-ray, and we try and test with a different consistency of food, like starting from the thin and to the thick. So we prepare a barium solution with a different consistency, and we present to the patient, and the consistency which is passing through safely we allow to the patient, otherwise we don't allow anything. So this is the gold standard test worldwide for dysphagia. These were my outcome measure. As I said, FOIS, penetration aspiration scale. This has to be 2 or minimum.
Persons for the session, Dr. Vasudev Savlani and Dr. Murli Krishnan. I would like you to conclude the session with your concluding remarks in short.
To be on a safe oral feeding, aspiration is when a food or saliva content went into the wrong passage, that is trachea. Dysphagia severity scale, 12 is bad, 0 is good. Bolus reduce scale, like after swallowing how much food is remaining in the throat. So 3 and less is considered to be good. Then laryngeal elevation, the movement of Adam's apple while swallowing, that has to be there. So that has a grading from 0, not functional, functional and weak functional. And the diet consistency which I showed. So dysphagia rehabilitation we provided to all patient. The session was almost 60 minutes, 5 sessions per week, and we gave both therapies, conventional therapy as well as the advanced therapies. And my hypothesis was that therapy only focused on the pharynx, because we know through the clinical correlation that this stroke only affects the pharynx, so no point doing oral exercises. So all the manual exercise and exercise through the modalities were focused on the pharynx. So this we divided the program. The patient who have some flicker in the Adam's apple larynx, we provided left side program, and patient who has some movement we provided, but overall patient was severe and on functional oral intake scale 1. So apart from the conventional therapy, we also added neuromuscular electrical stimulation and EMG biofeedback. Again, all were focused on the pharyngeal facilitation and strengthening. Just through a video, I would like how we did a biofeedback to a patient. As you can say, the sensors are attached onto the pharyngeal muscles, and patient is trying to gulp hard, and the waves, the action potential is showing that how much power he is putting. So this we can use as an objective assessment also, and as a feedback for a therapist. And this can be do in a various ways in form of this kind of graphs, and also it can be done in form of games. So this is the game, like the flower. So when patient is resting, the flower is closed, and when patient is working hard on the swallowing muscles, flower will blow up. So this way we can, so we have divided the result we got. Initial VFSS, as you can say, the food is not passing through the C6 level. In the FOIS 2, when patient started swallowing, some portion content went into the food pipe. So that was 2. And last, but again, as you can see, some food liquid content is going into the trachea. So this is called silent aspiration, when patient is not coughing, still aspirating. So finally, we proved that, okay, now everything is going fine, all the parameters are set. Then only we allowed everything oral and we removed the food pipe. So this was the ultimate video of the final phase. So food is going all into the stomach. These were the master chart of all 6 patients, demographic data, and some case glimpse, a magical transformation. The patient came in this form, and now you can see the patient is fat and eating comfortably and enjoying his life. Limitation was cases were less because of less long severity, long standing case. The conclusion that this kind of chronicity also we can treat, just need patients and focused treatment plan. And also proves that yes, neuroplasticity exists. Out of my 6 patients, 1 case came to me after 7 years. Since 7 years, he was on a feeding tube. These are my references. Thank you very much.
Can be motor, sensory, cognitive deficits with and without communication issues. Cognitive motor activity is apparently interlinked in a healthy brain. Post-stroke, cognitive functions get disrupted and additionally lead to various functional and communication deficits. Lower mobility, grip strength, and cognitive impairments are found to be interlinked among post-stroke subjects. Though lower limb functions carries valuable role of cognition, but upper limb functions has direct and utmost impact on the level of cognition. Reason could be attributed to the complex, coordinated, and high functional demand of upper limb in day-to-day activities. Fine hand skills, dexterity, and in-hand manipulation are predicted to be crucial for cognition. It may be inferred that upper limb control has direct impact on cognitive functions. However, no such specific studies has been found analyzing the relation between the motor status and cognitive level. The aims and objectives of the study were to find the relation between the motor recovery status and the cognitive level among post-stroke subjects, and to study the relation of function and disability with cognitive level. It was conducted in Neurorehabilitation Unit of OT Department of a Rehabilitation Institute. 43 post-stroke hemiparatic subjects were enrolled from the ongoing PhD thesis work, and it was a correlational study. The study was approved by Institutional Ethical Committee of the study site and from the concerned university where PhD is enrolled. The study is registered under Clinical Trial Registry of India. Consent form was signed by the subject and the family member after explaining the study details. The subjects were included with non-traumatic stroke, ischemic or hemorrhagic stroke, either right or left hemiparatic, brainstorm recovery stage arm and hand from 1 to 6, chronicity up to 3 years of onset, and age between 20 to 75 years, with or without shoulder subluxation. The subjects was excluded if they had severe communication deficits, severe contracture and deformity, severe cognitive and perceptual deficits, cardiovascular instability, and uncontrolled medical illness. These were the outcome measures used for the motor recovery measure. Brainstorm recovery stage of arm, hand, and lower limb. The arm, hand, and lower limb is from 1 to 6 stage, that is 1 considers the no voluntary movement to 6 to isolated and voluntary movement. Next outcome measure was the Fugl-Mayer assessment. It is the very validated motor assessment for stroke, that is Fugl-Mayer upper arm 18 items and 36 score, wrist and hand 15 items and 30 score, and it consolidates and makes 33 items and 66 score. FMA-LE has 17 items and 34 score. It is from 0 to 2, 0 no movement to 2 near to the normal movement. The cognition was assessed with Monterial cognitive assessment. The MOCA has 7 areas assesses, that is visuospatial, memory, attention, language, abstraction, delayed recall, and orientation. And author is MOCA certified. Function and disability was assessed with the Barthel Index scale, that is 10-item interview-based scale, used to measure the independency in ADL, and total score is 100. Modified ranking scale, that is 0, no symptoms, to severe disability. Functional ambulation category was also assessed to see the functional status of the subjects from 0 non-functional to the 5, that is independent ambulation. The data was analyzed using SPSS version 23 software, Spearman correlation test, to analyze the relation between FMA and MoCA. P-value was less than 0.05 as significant, and correlation value less than 0.3 as weak, 0.3 to 0.75 good, and more than 0.075 was excellent relation. This is the demographic data of the subjects. The mean age of my enrolled subjects were 47 years. There were 63% of the male and 56% were right hemiparetic, 93% were right-handed, and 72% had ischemic stroke. The duration of the stroke was 14.18 months, and speech, as far as speech is concerned, 11 were intact with any speech deficit, 22 had dysarthria and recovered to the level of recovery. The Broca's and Wernicke's were very mild in 7 and 3 subjects. This is the result showing the relation between MoCA and Fugel-Meyer assessment. Only Fugel-Meyer assessment of arm, wrist and hand, and upper extremity found to be weak but significant relation with MoCA. The FMA arm had 0.29 and significant at 0.05. FMA wrist and hand 0.29 and significant at 0.05. FMA upper extremity was little bit more significant, 0.334 and significant at 0.029. The Barthel Index, Functional Ambulation Category, and Modified Ranking Scale were found to be moderately and significantly related with MoCA scale. BI was at 0.621 and significant at less than 0.001. Functional Ambulation Category 0.42, significant at 0.005, and Modified Ranking Scale minus 0.375, significant at 0.13. This is the scattered diagram showing the significant but a weak relation. As you can see, the dots are little away from the midline. Wrist and hand is also weak but significant relation with MoCA, and upper extremity has a better correlation values than the wrist and hand and upper arm. Some of the motor components are evident to be correlated with the cognitive dysfunction, though there is variability regarding the level of association between the components of cognition. Cognition comprised of various higher functions of the brain with its diverse classification. Selection of cognitive assessment tool for stroke subjects is an area of disagreement. MoCA is a reliable and valid tool, but some of its components were found to be challenging during the application. It has been suggested and evident in the literature that MoCA score from 18 to 25 is mild impairment, 10 to 17 is considered as moderate impairment, less than 0 to 10 is severe impairment. Still further research are indicated in the literature to validate this categorization. Left hemi and right-handed could hold the pencil easily. That is the most difficult task in MoCA, the visuospatial component of MoCA. But right hemi and right-handed performed the component by left hand, that was their non-dominant hand. Visuospatial impairment affects motor learning and skill transfer. Visuospatial function has been linked to the motor skill learning also. Cognition is importantly needed in our day-to-day functional life. This could be the reason for moderate relation with the functional and disability measures. Poor hand grip is evident to be associated with cognitive issues in the literature. There is a role of frontal lobe in providing of both executive functions and motor control, forming the underlying basis for the interactions between the cognition and fine motor skills. These are the limitations of the study. MoCA does not detect moderate to severe cognitive impairment. Paretic side and handedness was the area of concern during the application. Educational status was also very difficult to apply, and severe communication deficits could not be performed in the MoCA scale. Hence, we can conclude that there exists a mild but significant relation between the motor recovery status and cognitive impairment in stroke. The function and disability status were also found to be moderately related with cognition. For For future studies, it is recommended that, based on such findings, stroke rehabilitation protocol should be developed and instigated. It may be applied to the large sample size, and studies with homogeneous subgroups may be studied. My sincere thanks to my guide and competent authority to permit me to present this paper. My sincere obligation to the participant and their family members. These are my references. Thank you.
All of you. So today I'm going to present this paper which is titled as Magnified Mirror Therapy for Unilateral Spatial Neglect in Stroke, a Feasibility Study. Stroke is the most common cause of cognitive and motor impairments. Among all the cognitive deficits, they include a disorder of spatial awareness which is known as unilateral spatial neglect, that is USN. This neglect can be defined as a disorder of perception or attention, or it could be action in the space or altogether. USN can reduce the ability to look, listen, or make movements towards half of the environment. It affects motor recovery and daily functions. Up to 90% of the subjects may experience this problem, and the range is from 10 to 90% depending on the different studies. It usually occurs opposite to a cerebral lesion and typically in the right brain damage. However, 30% subjects with a left brain stroke may also experience this problem. There are a range of approaches which has been applied for the management, such as cognitive therapy, behavior therapy, and pharmacological therapy also. However, no consensus for the most effective method has been proved yet. The technique is known as mirror therapy, which acts on neural mechanism of recovery in stroke. And in addition to this, there is a magnification aspect of vision that increases the cortical representation of body part. And there are certain studies which has been done on the magnification of this aspect in stroke, as well as mirror therapy in stroke also. Though the mirror therapy has been investigated for the unilateral spatial neglect, however, magnified mirror therapy has not been explored yet. So that makes the rationale of this study. And we hypothesize that illusion by magnified mirror therapy induces enlarged cortical representation and greater neural reorganization. And the objective of this study was to determine the feasibility of magnified mirror therapy, creating illusion for the affected hand, and to find the effectiveness of magnified mirror therapy on unilateral spatial neglect and its motor recovery. This study was ethically approved by the Institutional Ethics Committee. The study has been funded by Indian Council of Medical Research, and the study has also been registered in the Clinical Trial Registry of India. The study has been conducted at the Neuro Lab of a Rehabilitation Institute of Delhi, and it is a pre-post single-group feasibility study design with a sample size of 18 post-stroke subjects from an ongoing T-Maxence trial. The main inclusion criteria were the age 20 to 80 years with a 1 to 36 months post-stroke duration, hemiparesis of both the side right or left, and the neglect was defined as an asymmetry between the letter cancellation, task omission of at least 2 letters. I'll be talking about this test later on, and the normal visual abilities of with or without glasses. However, we excluded the subject with a receptive communication disorder, severe cognitive impairment less than 17 MMSE, or homonymous hemianopia, contexts or deformities of the hand, complex regional pain syndrome, or medically unstable subjects. Intervention. We used a magnified mirror of 2 times enlargement, and the left affected hand was placed in front of the mirror, that is the magnified mirror, to visualize the image. The affected hand was placed behind the frame. A magnified illusion was created for the paralytic hand. We can appreciate in this video, the subject is trying to do a finger flexion activity, and the image was magnified. He has hidden the paralytic part behind the frame and is doing the movement with the left unaffected or less affected side, and the illusion was created. Another subject, also right paralytic, she has also hidden the paralytic hand behind the frame, and she's doing the activity with the left hand, which gives a magnified illusion. The line bisection test basically comprises of 3 20-centimeter horizontal black lines, and the subject has to mark the center of each line. Errors were measured from the true midline, and anything more than 1.4 centimeter of error considered as a neglect of left or right side. While in lateral cancellation task, the LCT comprises of O's on an A4 sheet, and it comprises of 40 O's, 20 on the right side, 20 on the left side, with the 425 distractor letters, that is other letters, and the subject has to cross all the O's possibly, and if there are 2 omissions, and that will be considered as a neglect on the left or the right side accordingly. FMEWH comprises of 15 resistant hand items along with the coordination items, which is scored on 3-point scale ranging from 0 to 2, with a 0 means a no function, 2 means a full function. The total score is 30. The subject performing the resistant hand items. This is a flowchart of study which shows that we have initially assessed 47 subjects, out of which we enrolled 18, and the other patients were excluded for different reasons. And all the subjects were allocated to the intervention, they received the intervention. However, there were 2 subjects which were lost to the follow-up. Data was analyzed using paired t-test, with a p less than 0.05 was considered as a significant, and the 95% confidence interval was also reported. We used the IBM SPSS version 23 software. Results: the average age of these subjects were 54 years, with a 61% male. Their post-stroke duration was 8 months. There was 78% ischemic stroke, while 72% left-sided stroke. Majority of the subjects were there having a multiple brain involvement. For feasibility, we found that this magnified mirror therapy is possible, and all the participants could perform and complete the protocol. None of the subjects reported any adverse event. Only 2 subjects, as I told, were lost to the follow-up. These are data showing the line bisection test, which we found has been reduced from 1.54 to the 0.80, and this reduction was found to be statistically significant. The subject having a severe neglect initially before the intervention, and after providing the magnified mirror therapy as well as the motor rehabilitation protocol, the subject could perform his sit to stand activity in a comfortable manner or in an independent manner, which he was not possibly doing because of the neglect. Letter cancellation tasks, on these data we found that there is an increase of letter cancellation from 16 average to an 18.8. However, this change was not found to be statistically significant. FMEWH was found to be statistically significant. It increased from 10 to 18 on an average. Discussion. Perception of enhanced hand size may reduce the impact of unilateral neglect. I have to run to this video, otherwise it will get hang some hair in between. Okay. So this was the first study determining the effect of magnification on neglect. And we can again appreciate a subject performing this clipping activity, having a magnified view of the finger as well as the object, small object, and as well as the pre-hand style activities. So results of this study are consistent with the other mirror therapy type of studies which has been performed in terms of the reduction of the neglect in stroke patient. However, this study which has been conducted so far are without any magnification. And in general, it has been found that mirror feedback reduces the spatial neglect and enhances the upper limb recovery. Visual illusion of the affected hand recruits premotor cortex. The increase in the perceived size of the hand enhances latent motor cortex in terms of excitability, size, and efficiency. There are many versions of line bisection test. The procedures are rarely standardized. LCT or letter cancellation task is found to be more sensitive than LBT. Both LBT and LCT are not demarcating the type of neglect. Gold standard measures related to particular type of USN is not available. Some of the other limitations: heterogeneity of study subjects in terms of brain involvement, type of USN deficit, motor recovery stages were not possible. Only few subjects with a severe neglect were there in this sample. Determining the level of illusion by these subjects were also not feasible in this study. We recommend to conduct randomized trial with a larger sample size and the refinement of this protocol and further integrating of this therapy protocol with the existing motor mirror therapy protocols. I conclude, Magnified mirror therapy is a feasible intervention in stroke which may be utilized to reduce the neglect and enhance motor recovery. It could be considered as an integrated motor rehab protocol. These are some of my references. I would like to acknowledge Indian Council of Medical Research, director of my institute, patients and their family members. Thank you.
Persons for the session, Dr. Vasudev Savlani and Dr. Murali Krishnan. I would like you to conclude the session with your concluding remarks in short.
Thank you, Shrihas and OTCon24 team for giving the opportunity, and I'm so glad I sat through this session. You know, it's such a diverse area of service coverage, speakers, and the diagnosis wise as well. You know, people from the beginners to the stalwarts are standing there and then presenting something new in our field, and the innovations are varying from different fields: mindfulness, stress, and then something to the hand function, and touching base on old techniques with the new concepts as well. Only few suggestions for some of the people: just rework on the your headings of the studies, maybe when we are going for publication, that is needed. And very nice to see all the presentations going.
Yeah, you see, for Lakshmita, this laser and recreational activities definitely reduces the stress reduction. So we have to, these are main recreational activities has to be used more for stress reduction. That's what I feel. And Shaima, as I earlier said, it is just because of the competitive life of the students during that period that is causing that. And Swansea, adapted cognitive training in early elderly is a must, particularly in ladies it is required more. That's what I have found during the 50 years of work with them in my clinic also. So particularly ladies, they develop more problem with the cognitive. And Hitesh.
Yes.
Severe dysphagia, yeah, you have done a very good thing. It's a new thing. Probably it needs to be a little more pushed up in our field, occupational therapy, so that we will impress upon the masses. And Shanta Pandian, yes, madam, motor recovery definitely, as I see you said, no, there is between motor recovery and cognitive level, there is slight difference, as I found. There is slight difference because throughout the period of practice, no, there is not much difference as such. It doesn't look like. If the cognitive difference is severe, then only it affects more. That's what I find. Then mirror therapy. Kamala Arya, you are doing a wonderful job.
Thank you, sir.
I know it has been, you had been doing it for years, 2, 3 years, I think 4 years probably, and now you have started that modified this thing also. And you see, in occupational therapy, not much work has been shown in the world. Not much work has been shown in the mirror therapy. That's what I find. Through you see searches in the Google and other, no, not much work has been done in that. Do you agree with me?
Yeah, definitely.
You see, while last time when you conducted the course for the advanced treatments in the stroke, that time also I just went through all Google and searched and everything. Not much work has been done. Study has not been done much. So I think probably it needs to be explored more. Yeah.
Sure.
If we can help them, yeah. Thank you very much.
Thank you. Thank you. I request the chairs to hand over the certificate of presentation to all the participants. Jyoti Kumari. Lakshita Jaya. Shaima. Swansea. Dr. Hitesh Gupta. Dr. Shanta Pandian, ma'am. And Dr. Kamal Arya. I request R.K. Sharma sir and ma'am, Deepa ma'am, to please felicitate our chairpersons who sat all throughout. And a big applause to the audience here. I really thank from the bottom of my heart to be present here to boost the morale of the presenters. Yes, and thanks to all the presenters who sportingly accepted.
One thing is good that you see, in our occupational therapy, more and more ladies are there, and they are, I'm just very happy. Not in that sense. No, because they are involving in the new duty.
Yes. Innovation. Yeah.
They are exploring the world.
Yes. Thank you so much. Thank you so much. Murali Krishnan, sir. Thank you. And that's the wrap of the day. Thank you so much. Have a great evening ahead. Bye.